Os computadores são atualmente uma ferramenta obrigatória de um médico. Mas e se quiséssemos mais do que uma simples máquina de registros? Contamos com a ajuda do professor Leonardo Vannneschi e do investigador João Santinha, ambos especialistas na área da computação, para percebermos como a inteligência artificial pode ser uma ferramenta poderosa no nosso futuro.
Muito bom dia a todos. Como informámos anteriormente, esta sessão será em inglês. Before starting the session, I would like to thank Professor Leonardo and João Santinha for their presence here today. The next session will address the role of artificial intelligence in medicine, in this case, as a powerful helper to detect potential cancer masses in imagiology exams. With us, we have Leonardo Vannneschi, who is a full professor at novo AMS. His main research interests involve machine learning, data science, complex systems, and in particular, evolutionary computation. He has published more than 200 contributions, and he has led several research projects in the area. His work has been consistently recognized and appreciated by the international community. In 2015, he was honored with the award for outstanding contributions to evolutionary computation in Europe. For the second part of the session, we will have João Santinha, researcher at the Computational Imaging Group from Champalimaud Foundation. He is a PhD student at IST, University of Lisbon, and currently studies the application of mathematical modeling, statistics, and software development to support biomedical research and clinical research, mainly in the field of medical images processing and analysis. Now, let's watch the session on cancer, a new diagnosis paradigm. Professor, you can start when you want.
Thank you very much. I'm going to share my screen. Can you hear me?
Yes.
Very good. And can you see my presentation?
Yes, we can.
Okay, thank you very much. So thank you very much for your nice presentation. Before starting with my presentation, let me express at the same time the big pleasure and the big honor for having been invited and being here with you today. And at the same time, of course, as all of you, the disappointment for having to do this beside a computer from my home instead of being there together with you. It would have been extremely interesting and extremely important to be there physically and to exchange with you, but unfortunately, the situation is what it is. So let me begin with my presentation. I will introduce the use of artificial intelligence, at least for some applications in oncology. As it has already been said in your kind presentation, my name is Leonardo. I am a professor from novo AMS, where I am also the director of a lab in data analytics. As you know, this presentation will be shared together with my colleague and friend João Santinha from the Champalimaud.
Vai entrar agora. Faça-me uma contagem, por favor. Ok. Quando receber sinal, diga-me. É para eu avisar o professor para continuar a sua apresentação.
Okay, Professor, we are going to start the session in a moment.
Já está.
Okay, you can return to your presentation. Thank you very much, and I'm sorry for the trouble.
Okay, thank you very much. No problem at all. This is a part of the game, given that we are online. Don't worry at all. I was saying that I was going to make my presentation on introduction to artificial intelligence and its application from oncology. And I was saying that the presentation was shared between me and Dr. João Santinha, who is a part of the Champalimaud Foundation. And together we are joined in a project called the Binder Project, that is an FCT project, which is more or less in the middle of its development. It's a 3-year project and we still have 1.5 years to go. So as it is usual in these contexts, right? I am from computer science, so I imagine that I am from a different area compared to the majority of the people in the audience. As usual in this kind of context, the most difficult part for these presentations is to decide the right cut, the right level of abstraction, right? Between being too introductory and so too simple or too specialized, there is a halfway that is often not simple to find. So in this shared presentation, we have also decided to share the tasks from this point of view. So I will take care in this first part of the presentation about the introductory details. So among the different things that I will talk about, I will also make a very simple and general introduction to artificial intelligence. And later, João Santinha will be more technical and more into the applications. Nevertheless, in the second part of my part of the presentation, I will also present 2 case studies. Both of them, even though very different between each other, concerning the generation of predictive models by means of machine learning in oncology. So please follow me. I hope it is not too simple for many of you in this initial, very simple introduction to artificial intelligence, just in case some people in the audience is not aware or familiar with this concept that is artificial intelligence. So in my opinion, the easiest way to approach this subject that is artificial intelligence is to start from 3 basic concepts of computation: the concept of problem, the concept of algorithm, and the concept of program. A problem is a task that is typically to be executed automatically, performed automatically. An algorithm is a very precise sequence of steps or a process or an idea about how to solve the problem. And the program is a translation into a programming language of an algorithm. So what we can call the traditional computational method is made of 2 steps that correspond to the 2 arrows in this little drawing here. The first step is something like something completely artistic, right? Something absolutely not formal. And it is the fact that once we have a problem, we have to think about a possible solution, a possible strategy to solve the problem. And that's what brings us to the generation of an algorithm. While the second part is completely mechanical, because once we have an algorithm, we already have the solution and we only have to code it with a one-to-one translation between the steps that form an algorithm and the program, okay? In what we call the traditional computational method, that is what the majority of the institutions already nowadays do, still nowadays do, is the fact that this first step, the creation, the generation of an algorithm, or in other words, of a strategy to solve the problem, is manual. And it is in the head of an engineer, of a human being, okay? The problem is that this traditional computational method very often fails, and fails because in many cases it is either very difficult or impossible for a human being to imagine an algorithm, to imagine a very precise sequence of steps that can bring to a solution to our problem. And in order to have examples, I could imagine a client entering into a shop and answering the question, will this person be a good client for my shop, right? How can you answer by means of a set of formal points to this question? And of course, a lot of questions that we have in medicine belong to this class, right? And given that we cannot imagine a solution or a feasible solution to our problem, given that a human being cannot have in mind a solution to our problem, the idea is to give computers the ability to learn automatically how to solve the problem. And this is the main concept of machine learning, that is a sub-area of artificial intelligence. I could consider it nowadays the nucleus of artificial intelligence, and it is the part in which we are interested today in this presentation. The problems that belong to this big class that we could call complex problems, for which it is either extremely hard or even impossible to imagine by hands, manually, an algorithm, are nowadays more and more important, and they become more and more numerous thanks to the fact that we have more and more data, right? And so the problems in themselves become more and more important. And this is why machine learning is having such an importance, an increased importance nowadays. What does it mean to learn? Okay, what do we learn stripped to the bones in a nutshell? Well, I would like to say 99.9% of the times, learning means to the idea of learning a function, or better, learning a relationship between inputs and outputs. These that allow us to make the mapping between some inputs and some outputs is what we don't have, is what we are not able to imagine, and is what we want our machine to give us. So the problem, in general, the learning problem, can be defined as follows. We are normally given a set of data in which we identify a matrix of input data, okay, and the corresponding vector of expected outputs or target values. And we look for a function or a relationship phi, such that for each line, applying phi to the line, we obtain as a result the corresponding expected output. We obtain exactly that, or as much as possible, an approximation of that. This is the problem we'll have to deal. A little bit of terminology before going on. Phi, the function we are looking for, will be called target function from now on. D, the data that we have, the data set. We call learning the process that allows us to find a function f that approximates phi. So we are assuming that the data are related by means of a function, that the target function exists. That target function contains, in some senses, codes the knowledge that we have of the data. What creates the binding between the input data and the output data. And we are trying to approximate that theoretical function that we are supposing that exists with another function f, as much as possible similar to phi. F, the output of the learning phase, is called model or data model in our terminology. The expected outputs on the data that we have are the target values. And in the cases in which these expected values are known, at least for a set of data, we talk about supervised learning, and in the other case about unsupervised learning. In this presentation, I will focus on supervised learning. And on supervised learning, we typically have two big classes of problems: regression and classification. Regression when the target values are continuous, or informally speaking, very numerous, and classification when they are a limited number and discrete. In that case, mapping inputs into outputs can be seen as the problem of partitioning data into classes, right? It is exactly the same problem. An extremely important concept that is still part of the terminology that I'm going to define, but it is basilar, is the concept of generalization ability. So we don't want models that behave as the target function only on the data that we have. But we want models that behave as the target function that we assume existing, which codes the inner relationship between data, also for data that are unknown, that do not belong to the set of data in our possession. And this concept is crucial in machine learning. Just to say it simpler, if we want to predict the response of a patient to a cancer treatment, we don't want already to predict the response of the patients for the data that we already have, the patients that we already know, but we want to be able to predict for other patients the outcome, right? Generalization in some senses is not important, is the only thing that matters in machine learning, because we already have the answers and they are in our data set for some data. We are not interested in those, but we are interested in new prediction on new data. The machine learning process in general can be seen as composed by several phases, but stripped down to the bones, the phases are these. We always start from a data set that in some senses contain our vision of the reality, our information. it is given an input to a phase that we could call data preprocessing, that may contain several subphases like data cleaning, elimination of the mistakes, elimination of the things that are not relevant, feature selection, feature extraction, and so on and so forth. This gives as output a new data set that is typically smaller and possibly more informative about the relationship between inputs and outputs in the data. This is given as input, this new data set, to what we call an algorithm, a machine learning algorithm or method or system, okay? And the output of this algorithm, as we said, is the data model. The data model is then used on brand new data to make our predictions. So let us go very quickly to the part 2 of my talk, that is the first case study that I will present today. And it is a study that I did with my research group several years ago, actually 2012, so it is beginning to be somehow old, but it is the first contribution that I gave to oncology by means of machine learning techniques. And for some reasons, I still consider this contribution as one of the most important. So this is the paper. It was a comparison of machine learning techniques for survival prediction. Let's see a little bit more the contents of this paper. So the objective of the paper was classification of breast cancers into patients into risk classes, okay? And the challenge of that paper, which was something rather new at the time, is that we were using gene expression data, and not only clinical or histological parameters as it was usual at the time. And this was supposed to improve our ability to classify patients into risk classes. We have used for this work the 70 gene signature dataset for breast cancer that was presented in 2002 in Nature. It is a set of microarray features. So we are using microarray data. And we have used the NKI dataset that contains gene expression and survival data for 295 breast cancer patients. And of those data, we have only selected the features corresponding to the 70 gene signature. So taking out some other features that are part of this NKI dataset. The results in a nutshell, and here I am really making a long story very short, okay, is a big success of a technique, a machine learning technique, relatively new, that is called genetic programming. Genetic programming outperformed all the other studied machine learning algorithms for this problem, with several parameters, with several versions, also performing, as we will see later, a feature selection. Genetic programmings were robusted and they were tested on other datasets. Genetic programming could be specialized to minimize false negatives that are possibly more important than false positives and still would be able to return good results. And genetic programming was able to produce simple and arguably readable models. So genetic programming was important in this work. And so very briefly, what is genetic programming? It is a domain-independent method that has the objective of genetically breed a population of computer programs to solve a problem. So it is a method that is inspired by the Darwinian theory of evolution, which has these 5 main pillars here: reproduction, capacity of adaptation to the environment, inheritance, variation, and competition. The solutions here are computer programs, or in particular, they can be data models, and they are subject to a process that mimics the theory of Darwinian evolution. And this process is supposed to improve their quality iteratively. Genetic programming has at least these 2 main advantages compared to other machine learning methods. It performs an automatic feature selection on the run. So it is not, while it is generating the model, so it is not needed in principle with machine learning to make a pre-processing phase of automatic feature selection, and it produces readable and arguably interpretable models. Actually, this is how one of the best models we were able to obtain from the previous application looks like. Okay, we can argue if it's readable or not. Of course, we have to know what these terminal symbols are, but they are. This is a logical expression of some features that are actually genetic features of the patients. Of course, as always, the interpretation of this model is a work for a technician, for a medical doctor, okay? But we have to recognize at least that we were starting from a lot of features, and we only have a number of features in the final model that is equal to 6 different features, right? So the model automatically uses a very restricted number of features that some colleagues from medicine agree are extremely important and informative to predict our target. Very quickly, the second case study, and this is a work that I've done in collaboration already with the Champalimaud Foundation and in co-authorship with João Santinha. So João can say something more about this application in the second part of the talk. It is a work that's been presented 1 year ago at the International Conference on Computational Intelligence Methods for Bioinformatics and Biostatistics. It is about radiomics. You probably are aware of what radiomics is. It is a modern trend of oncology aimed at using imaging features to make predictions or to make other studies with machine learning. Okay, so the idea is that not visible to the eye, medical images contain some information that can be useful to make some inference about many things: the seriousness of the disease, the prognosis, or other information that are important for the patients, and above all, that are extremely personalized, because we know that every image is different from the others. So there are several different phases: the segmentation phase, the feature extraction, the analysis by means of one of the machine learning algorithms that we know, and finally, the interpretation of the model that should be a tool that helps decision, and of course will never replace a medical doctor, but should only be a decision support system. We have applied this kind of techniques to 2 data sets, one of patients of breast cancer once again, and the other one of axilla. The features this time were of many different natures, including radiomic features. And the objective here was to predict something else compared to the previous case. It was to predict pathology complete response after treatment with radiation or chemotherapy. The algorithm we used this time was different, just to show that several different possible algorithms can exist. It was not genetic programming as in the previous case. It was logistic regression. It is a rather simpler algorithm compared to genetic programming, because the focus of this work was another. The focus of this work was study of the features that we use with a very intensive feature selection phase and regularization. Regularization is a very important process in machine learning. Once again, stripped to the bones to make a long story simple. It consists in simplifying the functional complexity of models in such a way that they can become more general, and so have a better generalization to new data, and of course, occasionally being simpler, also more interpretable, possibly. The most interesting result that we have obtained in that paper is a very nice success of this new regularization technique, defined only in 2018, called priority lasso. These are the basic results, stripped to the bones, that we have obtained. And we consider this result on unseen data for the axilla dataset extremely important. All the results approximate faithfully the data, have an area under the ROC curve of approximately 90%, which is very reliable. It has been extremely hard to obtain this result, and it was not possible to obtain it with other regularization methods. It was the priority lasso that allowed us to obtain such a reliable result. Another interesting information is the importance of the features, right? In the case of the breast cancer, the radiomic features of the final model were predominant, 9 over a total of 12. And of these 9 radiomic features, 2 were tumoral and 7 were peritumoral. So we hint, in some senses, the importance of the peritumoral area for predictions in breast cancer, while the situation seems to be different for the axilla. First of all, radiomic features are not the majority of the features that have been selected by our machine learning system, 4/9. And of these 4, only 1 were peritumoral. So the peritumoral area seems to be less important compared to the case of the breast for the axilla. Said informally, we know that it's much easier to predict, to make prediction models, whatever they are, for breast cancer than for the axilla cancer. The axilla cancer, from a computational point of view, from a point of view of the machine learning system, is known to be a harder problem. I finish my first part, and I hope that I still have 1 minute to say this, with the big challenge for the future, okay? The big challenge for the future is not the technology of machine learning, is not what our computers can do. We know how to do it, and we think that the work and the technology is mature for that, but it is clinical validation of our models. This is something on which we are still a lot behind schedule, okay? Simply because we don't have enough data. We only have typically data from one institution. We cut a set of data for testing. Okay, this is good, but the data that we have cut for testing have the same type of images, the same characteristics, and so they are too similar, always too similar to the data that we have used for training. A simple mind like me that is not from medicine still don't understand why it is not possible to make a consortium, a global consortium between all the medical institutions in the world for sharing data. Why this can be a problem, why this is not possible. This would improve our knowledge and our machine learning tools of orders and orders and orders of magnitude. And this would be for the health of our patients, of course. Thank you very much for your attention.
Thank you very much for your presentation, Professor Leonardo. I now ask you to turn off the screen sharing and João Santinha to start his presentation, please.
Hello, everyone. Good morning. I will start right away. So I would like to thank the organization for the invitation to share this presentation with Leonardo. Thank you all for being here, and thank you, Leonardo, for the amazing introduction and to allowing me to go further and not have to introduce so many topics. So a big thank to you, Leonardo. So as Leonardo already said, and Fernando as well, the topic here, it's cancer and a new paradigm of diagnosis. And here, as Leonardo already introduced, one of the topics or one of the things that you can use to do this diagnosis is medical imaging. I think that you all know that medical imaging is an essential part of cancer diagnosis. MDTs often make the decisions on the best treatment for each patient using medical images. And this, of course, follows a standardized criteria to offer the best treatment to each patient phenotype. And this phenotype has a lot of tests, but it's known that patients with sharing the same phenotype according with these standardized criteria may respond differently. So one thing that we can understand is that the traditional phenotyping that we currently have may not be sufficient. As Leonardo already showed you some of the cases, there are a lot of advances in terms of genomics, proteomics, and other omics research that enable us to go towards a concept of precision medicine where you can better stratify patients, you have more phenotypes, and you are better able to select the best treatment for each patient. And where does medical imaging comes? So medical images are already acquired for diagnostic purposes, and they are very powerful, at least to our view, because they offer you a 3D visualization and therefore a 3D assessment of the entire tumor in a non-invasive and non-destructive way. Because of its non-destructive nature, it also allows you to have an idea of the tumor evolution. So you can scan it before starting the treatment, during the treatment, and after the treatment, and see if the patient is responding or not to the treatment. Of course, there are drawbacks. There is a lack of microscopy resolution within these images in comparison with pathology techniques. But this is evolving day by day. There are a lot of advances day by day in terms of resolution. So there will be a time where you are close to microscopic resolution. There is an issue with radiation. Some modalities offer radiation, although there are also efforts to reduce this radiation and have the image quality necessary to perform diagnosis. And here there is also the application of deep learning technologies to be able to reduce the radiation while being able to offer the same image quality that the radiologist can perform the assessment on. And as I already hinted, these images are assessed by radiologists. And this assessment, of course, it suffers from a variability in the interpretation due to different visual perceptions, training level, and degrees of experience by this radiologist. So what can artificial intelligence offer? You all know these new advances in terms of artificial intelligence that are able to put cars driving by themselves and other examples. So there is a lot of evolution in the recent years in terms of the computer vision domain. And one thing that we can also do, and Leonardo has demonstrated that and it has introduced, so he has made my life easier at this point, is that we can also apply these computer vision methods to medical images. And one example is radiomics, where you use these methods to extract a large number of quantitative images that may be used to obtain new imaging biomarkers that will provide some answers or may provide some answers for better patient stratification and management before biopsy, before going to surgery. So it follows the same concept of precision medicine. So I'm now just to show you like the basic hypothesis of radiomics and all these kinds of feature extraction techniques from computer vision, machine learning techniques. And the basic concept behind radiomics is that the tumor characteristics, either mutations, heterogeneity, aggressive, whatever you can think of, they may produce microscopic texture changes or patterns. So the tissue might organize in a different way when you have an IDH mutation status or a IDH wild type status of the genes of within the lesion of the patient. And this may be translated into texture organizations of the tissue that are different between the IDH mutation and IDH wild type, and be reflected and captured by these radiomic features, which are algorithms that will extract features and analyze these textures. You can think of several other possibilities, and here it's where you come in, creating the hypothesis, and we will test those hypotheses for you. And starting with some examples of works that we have developed in our group, so you can have a grasp of the immense possibilities. And this is just a very small subset of things that you can do. And this work was done by a master student, João Carvalho, at our group, and he developed a network that was able to perform the automatic detection and segmentation of lung nodules in CT images. You can see here a CT image of the lung, and he designed this network with some particularities. So his main idea was to build a smaller network than the traditional networks. that would be less prone to overfitting. So here you can see the performance of the detection block. So this model had a slightly lower sensitivity compared to the state of the art at that time. Nevertheless, it was a very good performance, taking into account that it was a much smaller network, easier to train on any computer. And here you see the performance of the segmentation compared to the ground truth, which is the radiologist segmentation. And you can see that his network is able to perform a little better than the state of the art at that time. So it was a great work by João, and it's very promising, and goes a bit against the flow that bigger models are always the best, and it's really interesting. The next work that I'm going to show was also done by another master student that we had there at our group working, which is Sylvia Almeida. And what she did was to create a semi-automatic tumor burden quantification in multiple myeloma. And traditionally, these images are whole body MRI images acquired from patients, and these patients have a lot of bone lesions. What radiologists do is that they perform the segmentation of the 5 largest lesions, because there are a lot of lesions within the bone, and to measure all would be an impossible task, taking into account all the tasks that they have to do, all the exams that they have to read during a day. But you can already understand that if the patient on a follow-up, and you always have to consider follow-ups to determine a response or not to treatment, and MRI is used to assess the treatment response. You can already see that if the patient lies a little bit differently in the MR scanners, the measurement of the major axis of these 5 lesions may also change, and you might be measuring a change that it's not an effective change. So the best option is to really quantify all the tumor volume. So make the segmentation of all the lesions and quantify this tumor volume. And that is what Sylvia did in a semi-automatic way. So it requires some inputs, but then there is a smart algorithm that will perform the segmentation of all the lesions. And more importantly, and this is an amazing result that we got from this, is that this allows also the assessment of changes using apparent diffusion coefficient, which is shown to show earlier changes after treatment than the tumor volume. So you write some weeks after treatment, you are able to make the decision to stop or continue this line of treatment of multiple myeloma based on this apparent diffusion coefficient, while based on tumor volume, you would have to wait a little bit more time. And as Leonardo already pointed out from the work that we jointly did, sometimes you gain more by putting different sources of information, not only radiomics, but also other sources, either clinical, demographic, genomic, whatever. So here what we assessed in this study was the symbiosis of radiomics and the radiologist to determine the breast cancer, whether the lesions were malignant or benign using 3D ultrasound images. And here you can see that using radiomics alone and comparing the radiomics performance with radiologists, what we saw was that the radiomics model was able to reduce 37.5% of unnecessary biopsies, and this is very important. You don't want to cause more stress to the patient, so if you can reduce unnecessary biopsies, it's a very useful tool. what we found, and it's interesting because here our belief is that it should be a symbiosis and not a replacement, is that radiomics plus the BI-RAD score provided by the radiologist was even able to even reduce further the necessary biopsies by 62.5% compared to just the radiologist. So you can see that there is a symbiosis and that you can, by working together. Going to another work, and I'm providing a lot of examples of different things that you can do. And here the work was on the prediction of malignancy in patients with IPMNs of the pancreas. And the main problem that you have here is that there is a very high rate of surgery for low-grade dysplasias. So the IPMN patients are divided into groups according with the type of lesion. So whether they have a low-grade dysplasia, they have a high-grade dysplasia, or invasive. Low-grade dysplasia is considered a benign lesion. High-grade dysplasia and invasive lesions are considered malignant. So the main question that we posed in this study was, can radiomics aid the doctors on this differentiation between benign and malignant, and thus reduce the necessary surgeries? And what we found was that yes, we can, although here there is an issue. We can perform better than chance both on the training, which is noted here in red, and on the test, we can see that there is a drop in performance. So as already Leonardo explained, we have this concept of generalizability. Can we perform well, and can we perform with the same performance that we got on the training when we are on the dealing with unseen data? So here there is a significant drop in performance when you compare the AUX and other metrics like the sensitivity and specificity, but nevertheless we can see that it's better than chance, but still room for improvement. Interestingly, if you consider that radiologically invasive IPMNs are easy to differentiate from low grades and high grades radiomics, you can also think of, so we can also tackle this problem as a differentiation between low grades and high grades. And here, interestingly, with the same data set, just by taking out the invasive cases, you can see that the model stops overfitting. So you have a test performance that is very similar to the training performance. There is a little bit of drop in sensitivity, but nevertheless, these are very good results and very promising results. And of course, as Leonardo has also said, we need more data, but these are very promising results. And the more data that you have to train your models, and the more diverse, the more robust likely the models will also be. So I also make the same argument as Leonardo. Please put also your efforts once you come into practice to share the data. Let's make all the data globally available so all the patients can benefit. Going to a subfield of radiomics, which is the radiogenomics. And what radiogenomics tries to do is a twofold approach. It's to study associations between genes, mutations, mutilations, and radiomic features extracted from the diagnostic images, in the idea that it will it will act as a virtual biopsy. And the second type of radiogenomics approach is to integrate both radiomic features and genomic information to improve the prediction of survival and treatment response. Of course, the more information that you can include radiomics, genomics, metabolomics, demographics, and clinical, the better likely the model will be, taking into account that you have some safeguards to select the features that are important and that are robust to changes in environments. And going to this topic of changes in environment, it's very common in medical imaging that different hospitals will have different acquisition protocols. Even if they are acquiring the same sequences, these sequences will vary a bit. And here in this study, what we did was to try to predict IDH mutation status using standard of care diagnostic MRI sequences. Why standard of care? Because not all the hospitals and all the centers are able to perform advanced MRI sequences. So we try to attain the same performance and even improve the performance of the prediction of IDH from diagnostic images using a new method for feature selection that also tackles the generalizability and performance issues when we are trying to predict images acquired with different scanners and settings. And what we found was that we were able, in fact, to generalize better with this new method, that we were able to have smaller models compared to the traditional approaches. So models with 1/4 of the features or 1/5 of the features than traditional models, and this is a very promising result. Although the drawback of these studies is the low number of cases, and we need more to verify this to further prove this. But it's a very interesting point that that we got there. You can think of several other, we did IDH1, but there are other several genes that have prognosis value for gliomas or glioblastomas. But not all of these are clinically tested very frequently. These are the ones that are most currently and most commonly tested in the clinical routine. There are some missing here, but I will show you just some examples of univariate analysis and explain a bit what we have here. And here, for instance, on the prediction of IDH mutation status, the solidity of the enhancing tumor part is the solidity of this hyperintense region over here in these images, which is also highlighted in green here. And you can see that the higher the solidity of the enhancing tumor part, the more likely it is to be wild type, while the mutated type patients have a lower solidity. And you can see that we attain very high sensitivity and very high sensitivity and a very high specificity. You can also do this for the TP53 mutation. You have the same type of analysis, and here it's the edema. So it's this bright region that you can see here on the flare image and on the T2 images. So we have the T1 post-contrast injection, the flare, and the T2. Each of these images provide different information, content, and you can extract features from each of these images. You have the PTEN, and here you can see that there is a feature that this feature has a very high sensitivity, but a rather low specificity. And currently what we are aiming for is to guide, to make the guiding of biopsies better. So we all know that tumors are heterogeneous, and biopsy, if done blindly, or it's not done blindly, but if not done with more information, there might be sampling errors. And what we are trying to do now is trying to come up with new ideas to aid this, the biopsies, guiding them to with useful information what might be the most aggressive part and what the most representative part for a better selection of treatment of these patients. So here what we do, what we are starting to do is to investigate the use of new machine learning techniques to select to create tumor regions based on the intensities of all these 4 different images. And this will create like regions like this. So there are 15 different regions with different behaviors in terms of intensities within the flare images, within the T1 post-contrast, within the T2, and within the T1. And these are called tumor habitats. So are regions sharing different behaviors or with different behaviors. And the main idea is that you would correlate these images with the excise specimens and make the correlation, which are the ones that are more aggressive, and in the future get this information on new patients and say, okay, you should get a sample from this specific red part, you should get a sample from this specific yellowish part, and so on. Following the same concept, we can also extract the radiomic feature and do it, extract the radiomic maps and gather these different behaviors of the radiomic maps, cluster them and create habitats within the radiomic maps, make the association with genomics biomarkers. Also, again, in the trying to guide biopsies with this, what might be useful information. So with this, I conclude the results that I wanted to show you, the examples. I want to acknowledge the radiomics team at the Champalimau Foundation and also the radiology department that helps in a lot of these tasks. I would like to thank you all, and a big thank you to the organization and to Leonardo. If you have some questions and there is no time, you all also have my email and my Twitter that you can reach.
Thank you very much, both of you, for your kind presentations. I'm sorry to have to inform you that we have no time for questions, so I will share your emails with our participants, and they can ask your questions later. I'm really sorry we can't promote the debate right now, but we have to move on to new sessions. I would like to thank you again for your presence here today and for your kind presentations to all of our participants. And I hope to see you in the next future. Thank you very much.
Thank you. Bye.
Thank you very much. Bye-bye.